transplantation. And I'm a consultant nephrologist at King Faisal Specialist Hospital and Research Center in Riyadh. So on behalf of the society, I would like to welcome all of you to one of the society's scientific activity. This webinar is organized by the society and sponsored by V4 company. So I would like to take this opportunity to thank our colleague in V4 company for sponsoring this webinar. And also I would like to thank the Eventru company for the technical support. This webinar is accredited by the Saudi Commission for Health Specialty for 2 CME hours. So on behalf of the society, I would like to thank the speaker and the moderator for accepting the society invitation. And also I would like to thank all participants for joining this webinar, and I wish you all to enjoy this scientific activity. Before we start, I have a few announcements I want to share with you all. This webinar, as I mentioned, is accredited by 2 CME hours, and this 2 CME hours will be entered in the participant account in the Saudi Commission, who wrote the registration number in the Saudi Commission in the registration form after a few weeks. The second announcement, there is no attendance certificate will be issued or sent to any participant. The third announcement I want to share with you, if you have any question related to the presentation, please do not hesitate to write it in the question and answer side in the screen. And our moderator will share those questions with the speaker at the end of the talk. The fourth announcement is a very important also announcement that the 8th Saudi Society of Nephrology and Transplantation Congress will be held this year in Riyadh at Crown Plaza RDC Hotel from the 5th to 7th December 2024. So I wish to see you all. This is a face-to-face Congress. So I wish to see you all in our Congress. This Congress organized every 3 years. And already this Congress accredited by the Saudi Commission by 24 CME hours. So I wish to see you again, all of you in our Congress. So without further delay, I would like to give the mic to my colleague, Dr. Abdullah Al-Ghamdi. He's a consultant nephrologist at Imam Mohammed bin Saud Islamic University. He will be our moderator of this scientific activity. Dr. Abdullah, mic is yours.
Thank you, Dr. Mohammed. Assalamu alaikum. Good evening, everyone. I'm Dr. Abdullah Al-Ghamdi. I'm adult nephrologist and associate professor at Imam Mohammed bin Saud Islamic University. Today, inshallah, we'll talk about CKD-associated pruritus with well-known international name, Prof. Puron Friedrich. Prof. Friedrich, on behalf of Saudi Society of Nephrology, I would like to welcome you. It's an honor and a privilege for us to have you tonight. Thanks for being our guest. Prof. Friedrich is a professor of nephrology at Eberhard Karls University, Tübingen, Germany. He has been working in the field of the nephrology for the last 20 to 25 years. He has more than 75 publications. He has an interest in bone mineral disease in CKD and non-CKD patients. Also, he studied many topics in hemodialysis patients, focusing on factors and biomarkers affecting prognosis, survival, and mortality. Prof. Friedrich, the floor is yours.
So thank you very much. I want to give you a short overview here about, I'll start my presentation. So probably now it's going on. Okay. I hope you have a good audio line to Riyad, welcome here to this webinar. Thank you very much for the invitation. It's the first time that I talk to the Arabic community. It's a great pleasure and honor for me about the new treatment modalities in the CKD-AP. And so I want to start immediately. This lecture is sponsored by We4 Pharma. And the first thing we have to talk about is the prevalence of the CKD-AP. And the best prospective data we have are from the DOP study. The DOP study are well known. They started in the mid-90s all over the world, also from the Gulf region. We have data, and they ask a very simple question to the patients on hemodialysis. They ask, do you have itching in the last 4 weeks? And the patients, about 70% of the patients say yes. I had itching in the last 4 weeks. So these are very high percentage of the patients. And for the moderate to severe forms, they're about 40%. That's all over the world in the same range. Here, like in the Gulf region, I show you here in the red box. Yeah. But this is also a very simple question. And they ask also about the incidence over the time. And you see the different DOPS data from the time points 1996 to 2001 and so on. And here about the 70% of the patients with itching, and there's no benefit at all. So that's why I was wondering about this, because we have now better dialysis water machines, filters, but there's no benefit in the field of the CKD-AP. And the patients have a great burden from this disease. And that's also a very interesting fact from the DOPS data that the medical directors have no idea what the patients that the patients have problems with the CKD-AP. So if you ask the directors, only about they say that CKD-AP is a problem for about 5% or less for the patients. That's not true. So the directors underestimate the incidence of this disease, and it's one problem from this story. The DOPS data are a little bit older. I want to show you some more recent data from Europe here about the prevalence from CKD-AP. These are a study from France. Antoine Lanoux presented this data last year on the ERA in Milano. And they ask about 1,300 patients in about 35 French dialysis units for the incidence of a CKD-AP. And they use a scoring system, a Wiener score. I show some slides later some more about this score. Very easy. It's if you have no itching, it's a 0. If you have severe itching, it's a 10, and the patients can quantify their problem. So that's a very important difference to the DOPS data, that there's a more detailed quantification. And they also ask for quality of life. And here are the data. So we have about 1% of the patients who have very, very severe forms. Yeah, they have sometimes suicidal problems or very mental problems with this pruritus. We have about 5% also severe forms, and we have about 17% moderate forms. So taken together, about 23.5% moderate to very severe pruritus. And these are probably the prevalence we also have in our facilities here in Germany. And what's also important to know is that for the, that about 40% of the patients or the doctors are not aware that about 40% of their patients have these problems. So it's very, very it's important that you ask a patient for these CKD-AP symptoms. I have also some data from the Netherlands from a Domestica trial. They make a longitudinal observation study on pruritus. There's about 600-700 patients. About 70% are hemodialysis patient and 30% are PD patients. So it's also an important question. If do the PD patients have the same problems at all? So this is a mix of the patients, and they got the same results. So about the severe itching and also the moderate itching is about 25% at baseline, and also after 3, 6, or 12 months. So, but it's not that the patients have itching and the other patients have no itching at all. It's a high variability of the CKD-AP, and that's shown in this slide. At the beginning, at the baseline, about 50% of patients have itching, and a part of them recovers, and other patients who have no itching develop these symptoms. So it's always a kind of variability in these patients over the first year of dialysis. So we have always to take care for the patients also for a longer time, not only for the first weeks at the beginning of the dialysis. And if I have a question for the PD patients, then you have to go to the Netherlands to the NECOSAT study. The NECOSAT study has a long history. So we have over a long period of time, they have shown that the PD patients has the same problems with pruritus and the hemodialysis patients. This is one very important fact from this study. And the other fact is that they look after the residual function of the kidney. And it seems that the loss of a residual function over years increases the burden of itching. This is also probably one of the fact that the residual function of the kidney removes part of the toxins which are also responsible for this itching problem. So that's the point that patients with a long history of hemodialysis or dialysis develop more CKD-AP than others. So let's go on to the clinical facts. The CKD-AP is often bilaterally symmetrical, can be localized, can be also generalized. So we have both forms of CKD-AP. And these are typical signs with scratch marks or prurigo nodularis or deep scars after a long term of scratching here on the back of the patient. And one point is the skin dryness. The patients, the dialysis patients have problems with skin, with dry skin. It's about 50 to 85% of the CKD-AP patients. It's additional factor. It's not the cause of the CKD-AP, but it aggravates the itching. So it's important to perform a kind of skin rehydration with moisturizing lotion or creams that helps the patients because the cirrhosis leads also to a poorer wound healing. So the skin should not be damaged. And this is the itch scratch cycle, a persistent problem for our patients. The itching leads to scratching, and the scratching leads to more inflammation, and so the itching is stronger and stronger with the skin damage and the inflammation. So we have to prevent this kind of itching all the time of the patients. So if a patient tells you, okay, I have an itching problem, there's a lot of different underlying causes, and we have to think about this. It's not only CKD. We have also liver problems, which leads to pruritus or HIV infection. There are primary skin lesions, that's for sure. It should be think about atopic dermatitis, psoriasis, prurigo nodularis, scabies, insect bites. So that's it's often also a problem. So that has to be should not be taken place. Also, very important thing is the use of morphines. We have pain patients. They get a high dose of morphines, and morphines stimulate the mu-opioid receptor, and this leads to more itching. So we often have patients, chronic pain patients. They go to the hospital and then they receive intense treatment for the pain, and then the itching is going worse. So take care for the morphines. Now, this is probably the most important thing what we have to talk about is to identify our patients, what we can do during our daily work. And my recommendation is a very simple question during the rounds for identification. Do you have itching problems? You have to ask your patients every 3 months, for example, and exclude alternative causes. This is very easy to do with no paperwork at all, and then you have an idea, has a patient a problem or not. And if a patient says, yes, I have a problem with the itching, we have to make an assessment for the pruritus intensity. And here I can recommend a very easy questionnaire, the worst itch numerical rating scale, Wiener's called Wiener's scale. Is very easy. I'll show you on the next slide. And for the other hand, we have to talk about the quality of life. And here we have also a very easy used questionnaire, the self-assessed disease severity, SIDS. And here are these both questionnaires. I show you first a Wiener score, very easy from 0 to 10, like the pain scales, you know them. And also the same for the life quality, where the patient can say, I'm mild, moderate to severe forms. So we have a good overview about the intensity and of quality of life from these patients. And I have this here also in the Arabic version. I would recommend to do this in a regular way, especially at the beginning in your sections, that you talk with your nurses, that every patient will get such a questionnaire, and you can identify the patients which have these problems, and then they can go on with differential diagnosis and treatment. Okay, so that's very important to identify the patients, because the pruritus is not only a symptom; it is also has a it has for the quality of life a lot of different diagnoses which are affected. So I show you at first the correlation between the itching intensity and the quality of life, and for sure, if the score for the intensity goes up, also the quality of life goes down. And there's a lot of different diagnoses. First, the mortality. This is also an important fact that the patients have with severe pruritus, they have a worse prognosis. So this is an independent factor for death, that these patients are very ill. And the severe pruritus, you see this is the surviving between the mild and moderate forms. There's not a huge difference, but the severe pruritus has a higher risk of mortality for these patients. I show you some more in detail what's been affected. Quality of life. Here this crosses are the extreme forms of itching is going down, but they have also problems with depression, with the sleep quality, with faintness, dizziness, or feeling washed out or drained. So that's for sure a problem for this patient, and so they have really a burden of this disease. Here are some data for the mortality, for the all-cause mortality. So it's also worsening with extreme forms, also for the cardiovascular mortality, and especially for the infections. That's for sure. If you have these scars and this inflamed skin, that you have the more infections, Staphylococcus infections in the skin. And this is also a reason why the people have to go to the hospital. So we have more hospitalization, especially from the infection, skin-related. And also here it's very interesting, also mental status changes or confusion is more in these patients because they are so affected by this pruritus. And in the end of the patients is also very often these patients withdraw more from a dialysis with extreme forms of a pruritus. They miss more treatments, they have more unemployment, and they need more recovery time. So probably this is a short overview about all these topics which are affected from the CKD-AP. And it's a complex pathogenesis of a CKD-AP. It's multifactorial, and it starts everything with the toxins. You know, we have a great variety of toxins in our body, and they have to washed out through the kidney. And if the kidney is not working, then you have accumulation in all the compartments of the body, especially of the skin. And these toxins have an influence on the neuropathy, on the nerves, and also on the immune system. So we have very often patients who suffer from, for example, diabetic neuropathy or uremic neuropathy, and they develop very often also the CKD-AP. And also for the immune system, we have more pro-inflammatory cytokines, more CRP, more interleukin, and that's a factor for the CKD-AP on the one side. On the other side, we have the endogenous opioid regulation, and I will tell you something more about this because the mu opioid receptor, MOR, and the kappa opioid receptor, KOR, they are balanced in normal way. And the mu opioid receptors is stimulated by endorphins or opioids, and the kappa opioid receptors is stimulated by dynorphins. And our Difelikefalin is a kind of dynorphin. Yeah? It's works like a dynorphin. And these receptors should be in a kind of balance. What is different now in our patients? Here are very nice slides from our skin, and this brown color is stained for receptors. Here we have the kappa opioid receptors, and we have here the mu opioid receptors. And you see the patients without pruritus, we have a balanced expression of these receptors in the skin. But in patients with pruritus, we have the mu opioid receptors, but here the receptors for the kappa are washed out. So this imbalance is one of the major pathophysiology factors for developing this disease. And that's also a question which is very often asked. What about the phosphate? You know, the nephrologist always thinking on phosphate and KTV and so on. But there is no correlation between the serum phosphate and the CKD-AP. There are data from the CALM studies, and they look for the phosphate here and the severity of pruritus, and you see such a cloud, so there's no correlation at all. Yeah? We have patients with very high phosphate and very low phosphate, and they have also high intensity here of pruritus. So it's for sure we have to take care that the patient has a good dialysis quality, but it's not the phosphate which is directly or influencing the CKD-AP. And also the patients, if we get here from a CALM study, the data for the treatment with Difelikefalin, so there's no difference at all if patients have a high or a low phosphate. Yeah, it works in both groups. So in your country, the Difelikefalin is a new therapy.
Prof. Friedrich, sorry for interrupting you. I think your voice is not clear. Can you just make the mic close to you?
It's okay.
Yes, now it's okay.
It's better. Sorry.
Yes, yes. Thank you.
Okay, thank you. So what is the current CKD-AP treatment at the moment? So how has been treated so far? In the first line, probably most of you uses antihistamines in an oral form or IV form, or topical steroids, and gabapentin. Gabapentin, especially in the second line, it was used very often also in Germany years ago. So I will talk a little bit more about the gabapentin. What are the data for the gabapentin? I have here an overview about all the studies with gabapentin and CKD-AP. And you see that these studies have very, very low numbers of participants, and the duration of the treatment is only 2 to 4 weeks, although very, very short. And if here on the meta-analysis, they use only 4 studies with 85 patients, a very small group. You see a benefit for the gabapentin. It's right, but here's it's very, very small numbers of patients. So and in Germany and all over the world, we have no admission for this gabapentin to treat the CKD-AP, so it's off use. And what's also important, the gabapentin and also for pregabalin, you should always keep in mind that it acts on the central nervous system. So with a higher dose of gabapentin, you achieve very often altered mental status. You have more problems with gabapentin, and a lot of patients cannot stay for a longer time on this medication. So keep in mind, be careful with higher doses of gabapentin or pregabalin. For the Difelikefalin, I want to tell you something a little bit about the mode of action. I told you before that this kind as a small peptide, very small synthetic peptide. It's work like a dynorphin on the kappa-opioid receptor. It's completely peripheral restricted, so we have no penetration in the central nervous system. That's important fact. And it's very high selective, and it's a full agonist on the kappa-opioid receptor and has no off-target activity. So we have no activity of a mu-opioid receptor. That's also a very important fact. And here the peripheral kappa-opioid receptors are these blue spots, and I will show you where can you find them. They are on the nerves, on the afferent terminal nerves, also on the ganglions, but they are also on the immune cells, on the T cells, macrophage, mast cells, neutrophils. So we have a two-component. We have also this suppression of a pruritic signal on the nerves without penetration through the blood-brain barrier. And we have a reduction of the pro-inflammatory cytokines. And both are important factors for Difelikefalin. And for Difelikefalin, we have here are the data from the CALM-1 and CALM-2 studies. These were the approval studies which are taking place in the US and also global. And they have patients, adult patients, also with no children, with end-stage renal disease and moderate to severe pruritus on hemodialysis. So we do not have data for the PD patients. They are on hemodialysis, and they are looking as an endpoint to achieve a more than 3-point improvement of a venous score. Yeah, why this more than 3-point improvement? This is then defined for clinical improvement for the patient. Yeah, so only 1 point you probably have no really clinical improvement, but this is defined to have a clinical improvement. And after a 7-day run-in, randomization 1-to-1 into the Difelikefalin group with 1.5 microgram per kilogram IV versus placebo 3 times a week after the dialysis. And this goes on for 12 weeks. And then we have for open label extension for 52 weeks. I show the results. So we have this more than 3-point improvement from a venous score. It was significantly better than placebo, but we have also for placebo an effect that's very often in this kind of studies for pruritus or pain, that the placebo group has also a benefit. But it was a significant improvement for the Difelikefalin in both study groups and also in the pooled group. So this is the same data. So we have a sustained improvement here for the open label over 52 weeks. The placebo group after 12 weeks changed from placebo to Difelikefalin. And so we got also this improvement like the other patients. And this is persistent over 52 weeks. And from our own data, I can tell you that also we have patients now for 2 years on Difelikefalin, and it's also working very well also over a longer period. So it's also an important message probably for you. So we have the question for the side effects of the drug. Yeah, that's also important. So if you look at all the side effects here, it's like the placebo groups, some special. I want to give you here an overview for gastrointestinal disorders. That's a point. So we have a little bit more diarrhea at the beginning. A lot of patients on dialysis have obstipation problems, so this is probably a factor against this problem. We have some mental signs here from dizziness, nausea, a little bit somnolence. This, in my practical experience, is only starting at the beginning of the treatment. And after 2 or 3 treatments, it goes away. So we have all our patients at the moment without any of these complaints I've shown you. What's most important is about the abuse potential. You know, we work on the opioid receptor, so it's very important that we do not have any physical dependence or euphoria, hallucinations. So in the CALM studies, they stopped the treatment and they looked for these patients, but they have no sign that there's any abuse potential or physical dependence in these data. So these are the approval studies. Now we go to the real world experience. We have here data from our region here in Stuttgart in southern Germany about the patients who go in directly with medication in the early access program. So there's about 14 patients. Also, one was treated in our facility, and they were very severe forms. And you see it here. This is a venous score again. After the treatment, most of the patients have a benefit, and they this benefit is also more than 3-point improvement, like in the approval studies. Only one patient has no change in this CKD-AP. And also for life quality, here's the severe impact, and here's no or mild impact. Most of the patients have a benefit. Only 2 patients, no change of life quality. So most of the patients have a better life quality. And a third important fact is the time to response. So 9 of the 14 patients responded to Difelikefalin within 2 or 3 weeks. So it's also important, a fast, a quick effect at the beginning. And if you have, after 8 weeks, no effect at all, you can stop the treatment. This is like we do. So I have some practical things for using the Difelikefalin. You use it as an IV bolus in the venous port of the dialysis circuit after each hemodialysis session. That leads to a high adherence. It's always important. So we have the substance in the body, and you have no burden for the patients to take more pills. And the plasma concentration of DFK is reduced by 70 to 80% at the end of the next dialysis treatment, because it's very high water soluble. Yeah, and that's the reason why it only works in this dialysis patient. If you would use it with a normal kidney function, it will be washed out immediately. So I show you also, like in the approval studies, with Difelikefalin, 0.5 microgram per kilogram, the end of a dialysis at each dialysis you can give. For the administration, again, the recommended dose, 3 times a week, IV bolus, venous line at the end, during the rinse back or after rinse back. You can give then some sodium chloride solution, or during rinse back, you don't have any additional solution to flush the line. You should not dilute the Difelikefalin, and you should not mix it with other medications. What about the dosage in different populations? First, if you have a very short treatment, so patient has to go to, you have to stop the treatment for any reasons, then you don't have to give it the DFK. You have no dose adjustment for patients with mild or moderate hepatic impairments, also important. For elderly patients, the same dosing recommendations as for our adult patients, and we have no data for the children at all. So what about the adverse reaction? Yeah, again, most important, the nervous system disorders, somnolence, dizziness, headache, probably is most important at the beginning of the treatment, and after 2 or 3 weeks, it's no problem at all in the patients. The same for diarrhea, for gastrointestinal disorders or mental status changes. Most of our patients in our dialysis centers come with a taxi to us, so they are not driving after the dialysis. You have to take care that the patient is in a good shape when he drives a car. So Difelikefalin has minor influence on the ability to drive and ability to use machines, but this you should take in mind. Also be, be careful about this. We have, what about the interaction with other drugs interaction? Very important, we have no interaction with CYP enzymes. That's important, not as a substrate, not as an inhibitor. Also for glucuronating enzymes or human transporters. So we have no interactions with other medicinal products. or they are very unlikely, and so you can give to the normal medication in addition the difelikefalin. Contraindication is only the hypersensitivity to DFK or any of the excipients. Okay, here taken together the data from the approval study, the CALM studies, again, with this intervention with the difelikefalin, 0.5 microgram after each hemodialysis for 12 weeks. It was well tolerated, and we have improvement for the itch intensity, improvement in life quality, and especially the sleep quality. And we have a really good effectiveness, and the adverse events are well tolerated. Yeah? So I have an algorithm for the treatment. Here for you, we have talking about the screening and the diagnosis. We use Wiener score. If a patient has an itching problem, if it has a mild form, we have a basement therapy. We have to take care for good dialysis treatment for sure. PTH, calcium, phosphate, I told you. We have to moisture the skin. That's very important to keep the skin barrier. This is the basement we have for all the patients. But for the moderate to severe forms, we use in Germany as a first-line therapy now the difelikefalin. And we make a follow-up for the next weeks and months. It's important, is a medication working or not? And the gabapentin we don't use anymore at the moment. I had one patient who died. He has a very, very severe form of the itching, and we treat him with difelikefalin and gabapentin as two components for more the neuropathy and also for the opioid system. So take care for the patients to a follow-up in the next months to modify the treatment or to keep the treatment. That's, I think, a very easy algorithm to go on with these patients. In the end, I want to show you our patients from the early access program. He was a very severe form, 66-year-old patient, a long time on hemodialysis, a lot of side diseases, restless legs, sleep apnea, reduced life quality, the Wiener score 9 as a very severe form. And here I show you these typical scratching lesions, so prurigo nodularis. We have a local therapy to moisture the skin. We had started some antihistamines during the night. We had also used gabapentin, but it was not tolerated. And then we start difelikefalin, September 22. And after a few weeks, he has a really increased quality of life, improved sleep. See the skin, it's really much better. So the Wiener score was 4. It was not completely went away, but it was really much better for him. And the life quality was better, also in his subjective opinion. And we go on with daily skincare and difelikefalin as monotherapy. So we don't use any other antihistaminics or something like this. So that was my short overview. I hope you have some very interesting questions. Thank you very much for your attention, and I look forward for your questions. Thank you.
For this an excellent and outstanding presentation. We will open the floor for the audience. Till I receive the question, I have prevalence when you compare hemodialysis and protein dialysis patients in terms of prevalence and severity.
Do you have a question for me, sir?
Yeah.
Abdullah, your voice was not clear. Can you repeat again?
Yes. I have a question, Prof. Radrich. Is there any difference in pruritus symptoms, like prevalence and severity, when we compare hemodialysis with the peritoneal dialysis patients?
No, there are no difference at all. We have in both groups the same problems at all. But the PD patients have very often a better residual renal function. And that's probably the point why they have at the beginning not this severe forms like on the hemodialysis. Also, the time on PD is much shorter than the time on the hemodialysis patients. We have here one patient is 40 years now on hemodialysis. And the PD have in average about 2, 3, 4 years. So it's probably one of the differences.
Abdullah, there is a few questions in the question and answer side.
I can't see it.
In the top of the question.
I can't see it, Prof. Dr. Mohammed.
In the question and answers.
Okay.
In the top.
Okay. It's probably
one ask here for the method what used for the assess to severity of pruritus. So we use this Wiener score. It's very easy to handle for the nurses. So every patient's got this questionnaire, and then he can mark about the severity of pruritus, or if he has pruritus or not. Yeah. And somebody asking for safety data for the Difelikefalin for the PD patients. So that's probably a very important fact. There are no data for PD patients. Yeah. So we have only approval for hemodialysis patients.
Yeah. So also, I have another question, if you don't mind, Prof. So I don't think so. We have the Difelikefalin here in Saudi Arabia. Like, what do you think about optimization, the dialysis prescription, targeting higher KT over Phe in treatment of CKD-associated pruritus?
Yeah, this was our concept over many years and decades. Yeah, to say, oh, the phosphate is too high, we have to increase KT over V. But it's not working. Yeah, there are data that it's not working. You cannot help a patient if you have a severe CKD-AP problem. It's not useful to do these things. Yeah, he should have for sure a good quality of a dialysis. That's for sure. For other reasons, also with the phosphate, but it helps not with CKD-AP.
So one more question, Prof. What's about the cost and duration of use of Difelikefalin?
So here in Germany, we have one dose costs about 39 euros, so about $40 per hemodialysis. So.
And in terms of duration, so we have to continue the therapy.
Yes, we have to continue the therapy. In some patients we try to stop it because some of the patients say, "Oh, it's very good. If I have no problems anymore," and then we say, "Okay, probably we can stop it." And last week we have such a patient, and we stopped it for 1 or 2 weeks, and then he started again. Oh, the itching comes back. So. Most of the patients we go on with the treatment, yeah. But it's okay to stop it after 3 or 4 months to try it if it's also okay when the skin barrier is okay. But most of the patients have to go on with the treatment. Yeah.
Okay. Thank you so much, Prof. Radrich. That was an honor and pleasure to us to have you here today. And I hope seeing you again, inshallah, in the future. So before we close, I Okay. Before we close, we have a 7-fold question about this topic, and each question will take around 20 to 30 seconds. So please, the audience, just answer these questions.
Indara, do you see the question?
Yes. Okay. I think we are done with the bold question. Again, I would like to thank you again, Prof. Pruritus.
Thank you. It was a pleasure for me. Thank you.
Yeah. Thank you. So just before we conclude this meeting, again, I'd like to thank our speaker, Prof, for his presentation and his talk. Really, we enjoy your talk, Prof. And also thank you, Abdullah, for moderating this webinar. And also I would like to thank all participants who join us this evening and for their active participation. Also, before we conclude, I'd like to thank our colleague who sponsored this webinar, F4 Pharma Company, for the generous support. And again, just would like to remind everybody about the upcoming Congress, the 8th Associated Nephrology and Transplantation Congress, which will be held in Riyadh at Crown Plaza RDC Hotel from 5 to 7 December this year, which is accredited by the Saudi Commission for Health Specialty for 24 CME hours. So I wish to see all of you there in our Congress. And Prof, again, we'd like to see you face to face in future, participating in one of the society activity. Thank you all, and a good night. See you, inshallah, in the upcoming activity of the society. Thank you all.
يعطيكم العافية جميعا وتصبحون على خير.
الله يعافيكم.
حياك الله. في أمان الله.
مع السلامة.
السلام عليكم.
مع السلامة.
حطتني ميوت يا عفرح يا ويلكم.
ميوت؟
والله ما حطيت يا دكتور، أنت ما عملت فتحت الصوت عندك. يعطيك العافية.
Prof already finished, so if you can leave, it's okay.
Thank you.
Thank you very much. Thank you very
Prof.
much, and have a good night to Riyadh.
Thank you.
Thank you.
Good night.
Good night.
Thank you. Have a good night. شكرا دكتور محمد لحضرتك جدا.